Hi, my name is Sam Stewart, and today I'm going to be talking about the research that I did in my first lab rotation in Dr. Axel Krieger's lab, where I focused on patient-specific aortic grafts for congenital heart defect repair. Just to give you a little bit of background on the problem, congenital heart disease is actually the most common birth defect, and it's just a functional abnormality of any of the portions of the heart or the great intrathoracic vessels that carry blood away from or to the heart. This disease is reported to affect approximately 1% of all live births, which translates into roughly 40,000 infants being affected in the U.S. each year. Now, 1 in 4 of these infants will have defects that are termed critical, and they'll require major interventive surgery to repair the defect within the first year of life. One of these common defects is the aortic coarctation, and what this is simply a narrowing of the great vessel that carries blood away from the heart into the rest of your body. Now, this often occurs in conjunction with other defects like left heart defects or a hypoplastic arch, which just means your arch is smaller than normal. And this defect creates a higher pressure upstream of the narrowing and a lower pressure downstream of the narrowing. And that requires your left ventricle to work extra hard to try and overcome this narrowing to pump blood to your body. So if the narrowing is very severe and your left ventricle isn't strong enough, this could result in congenital congestive heart failure or inadequate perfusion to the rest of your body. In these such extreme cases, surgical intervention is required to repair this defect and restore normal blood flow. A lot of different surgical approaches have been developed to attack this problem and restore this blood flow. One of the most common is this end-to-end anastomosis, where you simply resect the tissue and you suture the two ends together that are left over after resection. And these other approaches have been developed because aortic coarctation can vary in severity of the narrowing and even location on the arch or aorta. Even after successful surgical correction with these approaches, patients are still seeing heightened cardiovascular risk in the form of late hypertension and post-surgical aneurysm formation. And a lot of patients actually have to come in for follow-up procedures even when the first surgery was deemed successful. Now, studies have shown that the actual shape of the arch plays an important role in these disease pathologies and in hemodynamic patterns that they're seeing. So when a surgeon approaches this problem, they base their repair on intuition about how the blood would flow and experience. They don't have any real concrete hemodynamic information about how the blood would flow through their proposed surgical correction. And we've seen this Gothic arch has developed after successful surgical correction and is associated with late hypertension and certain patterns of wall shear stress. So using this information, we think that we identify a need for a personalized approach to aortic coarctation that takes into account hemodynamics. So we propose patient-specific grafts designed with computational software to optimize the hemodynamics and improve patient outcomes through an ideal arch shape. And we propose that because we've seen that CHDs are very heterogeneous and the shape of the aorta affects hemodynamics, which in turn affects disease pathology. So our proposed methodology to address this problem is pictured here. Basically, we take imaging data and convert it into a digital model that we can work with. And we'd manipulate that model to design a graft that we think would outperform the native tissue, and we'd test that design right here until we find an optimal design and eventually, hopefully, manufacture and implant it in the patient. So just to walk you through one of the processes I did, I took the MRI data and I converted it to an STL file that I could work with in CAD, and here I'm isolating the tissue that I'm looking at and making a model that I can work with. And then I resect the defect of interest and I replace it with something that I think is going to function better. And here's where I test my design computationally, looking at wall shear stress. Now, as you can see, here's the native tissue, and we see a peak in wall shear stress right at this area, which is right where the narrowing is. And through my optimal design of that longer arch, you can see that portion is mitigated, and we were actually able to reduce peak wall shear by 60% compared to the native tissue. So going forward with that work, I would just like to do more iterations in patient cases to see the effective parameters like arch shape and length, verify those computational results with in vitro to make sure the values I'm getting are physically relevant. And the long-term goal of this project would be to automate this design process and apply this workflow to other CHDs. So, thank you.